two types of diabetes. Based on the human studies, we know that there is type 1 and type 2. The type 1 is more frequently found in dogs, we consider older patients, and is related to not enough amount of insulin production. When the type 2 is more an inability to respond to insulin, so insulin is initially produced at a normal level, but there is something that impairs its function, and that's more frequently seen in cats. It's also present in dogs, obviously, but cats tend to be more typical with the type 2, when dogs are more frequently presented with type 1, which obviously will influence the treatment and management of this patient. So, very quick, some physiology. We know that nobody likes physiology, but we just need to stress out that insulin is not only affecting the glucose. There are a lot of effects of insulin that helps to absorb glucose. We say that sodium, potassium, amino acid, and fatty acid as well. And there is a lot of hormones that are interacting with the effect of insulin. Insulin is the only hormone that will decrease the glucose, but there are a lot of hormones that will increase it, like the glucagon, for example, or the catecholamine, the stress hormone. And again, that will be important, especially for some disease that will increase this level of stress hormone, or if we are talking about the SOMO-G effect, we're going to talk about this in the next few minutes. And overall, if we summarize the function of insulin, is that it does mobilize the energy for the body. So what does happen in diabetes? You start to have hyperglycemia because the insulin is either not produced enough or there is inadequate function, and that does induce polyuria and polydipsia. So the sugar in the blood will be filtered in the urine, and this presence of sugar will attract water. So the primary sign that we see generally is PCD. The second abnormality that we see frequently is weight loss. Despite having a lot of sugar, which is supposed to be a lot of energy, the cells are not able to take the energy inside the cytoplasm, and therefore there is weight loss and metabolic failure. And this weight loss will increase the appetite. With these three signs, so weight loss, increased appetite, and PUPD, will be generally the most frequent sign that we see. So diagnosing diabetes is relatively easy. It's relatively easy to suspect it with these clinical signs, and it's relatively easy to diagnose it. Let's say for dogs, not always that easy for cats, and we'll go again talking about that later on. So the two main tests that we can do are urinalysis and blood glucose. I would say that I favor urinalysis. It's quite a good test, because if you have glucose in the urine, if you have no glucose in the urine, it's very, very, very unlikely, if not impossible, that the cat has diabetes, or the dog has diabetes. So I really like urinalysis. It's a stress-free test as well. It can be just a sample taken by the owner at home and brought to you. So even before doing blood tests, you have a lot of information just with the urinalysis. But obviously you need to confirm your glucosuria with the blood test. Fructosamine can be an additional tool that can be interesting. I'm not a big fan of fructosamine, we're going to talk about that later on, but can be useful in cats which have, as you know, all of you, stress hyperglycemia, so you tend to have high level of glucose because of stress, and therefore fructosamine can help you to decide if it is a prolonged hyperglycemia, or if it's just a one-off due to stress. So that's the diagnosis. As you can see, it's quite short, but there is not a lot to say about the diagnosis of diabetes. Hello. Long day. So the management probably is more tricky, and that's probably what is more interesting for all of you. The goal of the treatment is not as I say, very rarely we advise once daily. And the diet, we're going to talk about the diet. We say that they have more type 2 type of diabetes, so they may not necessarily need insulin. That's the theory. In fact, when we see our patients, they tend to already have a lot of clinical signs, and when we diagnose diabetes, it's often too late. And we're going to talk about them. Unfortunately, they do have glucose toxicity. When excess of glucose in the blood will impair the production of insulin, and we have then a vicious cycle that starts to happen. And again, a lot of studies have shown now that for the starting insulin when they are truly diabetic, starting insulin early and relatively aggressively tend to improve the outcome. We're going to talk about diet as well with cats, and you'll see that there is a difference between dogs and cats. But what is important in cats is to find, if possible, an underlying cause and treat it. And if possible, do that earlier, at the early stage of the disease. The earlier you correct the cause of insulin resistance, the more likely you will improve or even resolve the diabetes. So what sort of insulin do we have? I think probably we are all using can insulin, you are all familiar with it. That's the only licensed insulin that we have in the UK. It's a very good drug. We all use it. It's not a good drug, but I talk about the other insulin as well. But you are supposed to start with it. Okay? Whatever you think about it, it's a drug that normally is the first line of treatment. It's quite specific, and I just want to stop there, especially for the nurses. It's the only insulin that is made for 40 units per milliliters of products. Okay. All the other insulins are 100 units per ml, and that's why there is a specific type of insulin syringe for can insulin. So again, according to the cascade, we need to first use can insulin, but if it is not suitable, we can try to use other insulin, so mainly human insulin. And we have different types of insulin that are available. We do tend to use the soluble neutral insulin for patients that are quite critical with diabetes ketoacidosis, and because we need a rapid onset of action. But always we're going to talk about the peakless insulin, that's how they are called. It's not always the case for all the patients. Again, we have an example at the end. But there are two that have been studied quite a lot in dogs and cats. So glargine, which is the Lantus, and detenir, they both act as being slowly released in the body, and therefore there is less fluctuation of the glycemia and may improve. They do improve, in fact, has been proven, the control of diabetes both in dogs and cats. I think it's a bit more historical, but cats tend to receive glargine when dogs tend to receive levodopa. Okay? But there is absolutely no contraindication to use one for the other. Levodopa is not particularly well designed for small animals, and especially for cats. You tend to have difficulty to draw the dose with levodopa, but it is not infeasible. As you can notice, it's different type of syringe as well. There is quite a variation between patients for insulin. So if someone starts to say insulin will always work the same, that's not going to work. Okay, it's quite different. Every patient will have his own way of metabolizing, absorbing the insulin, and what would be a quick onset of action for one dog may be long for another one. So unfortunately, we need to monitor that. Quickly about the diet, it's not really a strong treatment for diabetes in dog. In theory, increasing the level of fiber may decrease the postprandial hyperglycemia that can be seen with diet that do not have a lot of fiber. You have a slower onset of absorption of glucose. I'm personally not particularly bothering the owner of my patients with diet, because I don't have the impression it does improve massively the management of diabetes, but it's definitely something that can be interesting for cats. So in cats, it's very important, as we said, to control the cause of insulin resistance, and one of it is obesity. Obesity can contribute to insulin resistance, and in cats, obviously, decreasing the calorie intake may then decrease the obesity and reduce the need of insulin. So it's very important in cats, probably more than in dogs. If you have an obese dog, you will have the need to decrease the calorie intake, but that's especially important for cats. And cats are carnivorous animals. They really need high level of protein, and it's recommended to give them a low level of carbohydrates and to reduce the hypoglycemia. We don't really recommend to have strict meals for cats. They tend to eat through the day, and there is absolutely no effect in cats of this behavior compared to dogs, because they tend to have less postprandial hyperglycemia. So it's not very important to associate the insulin injection with the meal in cats, and it's no problem if they are just eating through the day. So the very important thing, and that's for both dog and cat, so yeah, skip the dog slide, but basically it's very important to keep the diet consistent. Whatever you choose, either a diabetic diet or a more classical diet, even the previous diet of the owner, it needs to stay consistent. Every time the owner will change it drastically, then that may change obviously the absorption of nutrients and the metabolisms and the reaction to insulin. So it is important to keep a routine, and a diet is part of this routine. So again, that's for the insulin resistance. When there are concurrent diseases, when there is obesity, that will contribute to insulin resistance. That's especially true for cats, and so managing these diseases may resolve the diabetes. That's more something that is recognized. So we're going to talk about the causes of insulin resistance now. Most frequently, it will be an infection. For example, UTI is quite frequent. Up to 30% of the cats with diabetes will present with a UTI. Or any kind of chronic inflammatory disease or immune-mediated disease may induce insulin resistance. I will add on this list, I don't know why it's not there, neoplasia is obviously another cause of insulin resistance. Obesity, we talked about that, and all the diabetogenic hormones, so stress hormone, but also all the growth hormone, progesterone. And there's one thing that I added: do not forget inadequate technique or abnormal insulin or inadequate preservation of the insulin. Okay? And that's probably the part where nurses are the most valuable. I will explain to you something that happened recently with one of the cases that we present at the end. Something that without a nurse I probably would have missed completely, and this patient may have had a lot of investigation for something that at the end was just a simple question related to the insulin. We'll talk about that. Keep up with the mystery of it. So that's an example of a patient that will have insulin resistance, a dog with Cushing. Very frequently it's difficult to stabilize this patient. So it is important to recognize that, and that's not an easy thing to do as well in Cushing. But when you have recognized it, it's important to treat it. You have difficulty to manage your diabetes if you don't treat your Cushing. Same with thyroid. That's a case of Jane that she has seen at the RBC, I think. And it was before and after hypothyroidism treatment. This dog diabetes management went from being completely uncontrolled here to be just a normal classical insulin without complications. Cats are always a bit different. They do tend to have their specific problem. Urinary tract infection is for both species, but they do. Hello. Very fine,
got their squeeze in there.
They do tend to have chronic inflammatory disease, including cholangiohepatitis or pancreatitis. So please do check for these. Recent studies have shown that even if there is no clinical signs for pancreatitis, the level of cats, the percentage of cats with elevated FPL, so feline pancreatic lipase, is quite high, from 20 to 30%. It doesn't diagnose for sure pancreatitis, but probably in this population there are some that do have inflammation of the pancreas. Cats are frequently treated with steroids. They tend to have a lot of immune-mediated disease, skin condition, and they don't tend to like shampoo, so they tend to be treated by steroids. And sometimes we don't have the choice, but if you have the possibility to avoid steroids, then do it. And it's very important, especially for cats that are obese or have other risk factor, to explain to the owner that steroids in cats can be associated with diabetes. It's probably going to be more important than the other signs that we see in dogs, which are CPD, hunting, muscle wastage. In cats, that will be mainly development of diabetes. And then endocrine disease, they have their own, obviously, hyperthyroidism and acromegaly. Okay? And we did talk about that. In cats, there is a specific element that happens with diabetes, is that the glucose is toxic for the cells that are producing the insulin. And therefore, there is a vicious circle that do happen. Excess hyperglycemia will decrease the insulin production. That's what we call glucose toxicity. And it's very important then to decrease this hyperglycemia if we want to achieve a resolution and have diabetic remission. So how should we monitor our patient and that we talk about the treatment? That's probably one of the trickiest way. I don't know if you have some idea of simple way of monitoring diabetes. What do you use in your practices? So what will be the elements that you use for this? Don't be shy.
Weight.
Yeah, weight.
PUPD.
Yeah. Yeah, at the time. So the clinical signs, I'm very happy that you started with these. The clinical signs are probably the most important, and well done, you've got 3 out of 3. So body weight, PUPD, appetite are very, very important to monitor. And I don't know how it works in your practices. In Willows, most of the diabetic, when they have been seen before, most of the diabetic that are coming for glucose curve are admitted by nurses. And we do rely on them quite a lot to gather this information and help the clinician to understand if the patient is stable or not. Because you can have a very nice glucose curve, but if your patient is losing weight, you are doing something wrong. You need to understand. Okay. So that's indeed clinical signs, the most important thing. And then we can rely on blood glucose, we can rely maybe on fructosamine, or potentially on urine glucose. So talking about this, let's see if we can trust them and let's see what you think about that. So when do you think is the best time to measure one single spot glucose? Is it at time of insulin, 2 hours after, or 2 hours before insulin? What do you think? You think it's at time of insulin? 2 hours before?
Depends what you think's going on.
Yeah.
Yeah. Do you think it's in remission?
So that was a bit tricky. I'm sorry. But all of these times are important. We did mention that there is marked variability between patient and those who are responding. I would say it can be variable with the same patient as well. So it's not because the nadir on one day is 4 hours or 6 hours after the insulin injection that it will always be the same. And a single blood glucose is useful to be sure there is no hypoglycemia at that time, because that's probably the most frequent way I would use just a single blood glucose assessment. But it will not tell you if your patient is well controlled, unfortunately. So we do need glucose curve. We are well aware of the difficulty to do glucose curve and to interpret them, especially in cats. And there is an example on that on one of James' patients that have been treated to diagnose. So we know that it's not always ideal, but if you take blood, then at least consider blood glucose and not a single blood. Okay, so we're going to talk about fructosamine. Do you think that fructosamine is useful to differentiate insulin underdose from an insulin overdose? Would you use it? Would you trust it? You know, there's some tricks, you know. No, you cannot. And again, I'm not a big fan of fructosamine. I do use it on occasion, but you need to be very careful in interpreting fructosamine. That shouldn't be the only test that you use for monitoring your pets. It's very important. Clinical signs are far more important than the fructosamine. Okay. So the main problem with fructosamine is the SOMO-G effect. So the SOMO-G effect is when you have at some point hypoglycemia because the patient is receiving too much insulin, and the normal reflex of the body is to secrete diabetogenic hormones that will increase again the glycemia. So you will have a drop, and then you will have an increase again. And unfortunately, the fructosamine is more influenced by prolonged hypoglycemia than by one transient hypoglycemia. And this SOMO-G effect can be prolonged up to 48 hours with only one moment the patient is hypoglycemic. So that has been shown with patients that have continuous monitoring of blood glucose with implants. They have one moment of hypoglycemia. They still receive the same dose of insulin, but they have prolonged hypoglycemia. So it is easy to miss it. And I think there was so on this one, that was one of Jane. Unfortunately, if she hadn't done a 24 hours glucose curve, she would have missed that. That doesn't mean that all the 24 hours glucose curve will find it, okay? But just she was lucky enough to do that for a long time to see it. It is well possible, and most of our patients will be seen during the day like that any of us would have missed that, and interpret that as the patient is not necessarily well controlled. That was not too bad, to be honest. The glucose was still too high for a patient that we consider uncontrolled, especially because this patient will have a lot of clinical signs, so you tend logically to increase the dose. And everybody has done this mistake, probably more than once. We all did that, I did that. So we're going to see how we can manage these. I think there are the slides about that. So fructosamine, I don't like it. I will add another inconvenience of fructosamine. Fructosamine is it's basically protein that have fixed glucose. So the longer the protein are staying in the bloodstream, the higher the value will be. Everything that will change the metabolism of the protein, and I speak about the thyroid hormone, for example, will influence the level of fructosamine. An hyperthyroid cat will have lower level of fructosamine than normal cats. And that's the opposite for a dog with hypothyroidism. They can have high level of fructosamine without necessarily having diabetes mellitus. We don't tend to use fructosamine that much in dogs, but still it is something to take into account. So, can we use urine testing to monitor diabetes control? What do you think? You don't know what to say now because you know that's going to be tricky.
Some bits.
Yeah, exactly. And so, yes and no. So, I do use that all the time. All the honor of my patients, apart the one that are particularly irritants and that will create problem, have keto stage because I think it's very important. But what I ask them to do is to regularly, not all day, What was the last name of the that if the patient is being wounded or breaking from the we are in a lot of people saying that looking at the type of insulin as well. So which insulin is used with lantern, what is the dose they are on, and when they are giving it. And again, what you prescribe as a vet is not always what people are doing. So it's very important to double check the dose that they are using, how they are injecting it, and I do recommend, at least for the beginning, to have a consultation with them and to show you what they are doing the injection. Not necessarily the insulin injection, but I can just they are locus line, just to see if they are able to do a proper injection without too much stress, but again, it's often quite a stressful treatment to do for them. Nobody is used to the injection in the center. So a bit more information, and again we will talk about the syringes later, but the storage of the insulin is very important. How do they mix that? When was this bottle started? And that's where I'm going to stop and talk about the patient I almost missed. So it is a patient we will see at the end of the presentation. Alfie, a nice dog that had a very complicated diabetes to stabilize. You will see his skirt, it's horrible. He had been stable and had been stabilized by Jane for months. And when she left, she passed the care on to me. And to the point, because the owner of this dog is lovely and the dog is lovely itself, so there is absolutely no issue. I thought that as soon as Jane went away, the glycemia seemed to be completely uncontrollable. Classical. And I had a lot of difficulty to understand why. I have been even increasing the dose of insulin, and there was some insulin resistance. Couldn't find any obvious UTI on the urine sample that the owner was doing. And I admitted the cat at some point for ongoing investigation. The plan was to do an abdominal. The plan was to do an abdominal scan to see if there was any reason why the dog was losing weight and was having maybe insulin resistance. Up to the moment that one of my nurse, Tom, I don't know if you know him, quite nice guy, just went to see me and say, Julian, is it normal that the bottle is out of date from like the last 18 months? And that was the problem. So basically, this lady had given levemir to this dog for a long time. It's quite an expensive insulin compared to cane insulin, and she had bought a batch of it to reduce the cost, without noticing that this batch at some point will be out of date. And she had been giving a lot of that insulin that progressively lost its action, and we were almost blaming a disease on the patient and be ready to do some kind of investigation, so cost and stress for the patient. When in fact, if I had asked this question, the case would have stopped everything. And that took a bit of time to realize that, and I'm really grateful for Tom to have found that for me, because I would have been very stupid. So we'll talk about the syringes. Levemir, that the insulin that this dog has, needs to have 100 units per ml syringes. They tend to have an orange top. When the cane insulin ones, they have the red top, and it's 40 per milliliter. It is extremely important not to be confused, because if you do a mistake, and again that happened in Willows, thankfully to one of our surgeons' own cat, if you make a mistake, you can either give only 40% of the dose, or more dangerous, 250% of the desired insulin. Okay? So this cat I was talking about was receiving Lentus, the cat of Stephen Baines, and had been admitted for just hospitalization while Stephen Baines was away. And unfortunately, the calentin syringe has been used. So these cats received then the 250 times the dose. And we were wondering why this cat was really unwell the following day. He had massive hypoglycemia. Stephen Daisy didn't comment too much on that, but I think he was quite disappointed about that. And unfortunately, that's a mistake that can happen everywhere. We do have some protocols to avoid this sort of problem. As you can see, sometimes that can still happen, and it's very important because it's life-threatening. This cat could have died from hypoglycemia, could have had seizures. So it's a very important thing to look at, and that's again one thing that nurses need to know and recognize. And the protocol that we have is to keep the keep the correct syringes with the insulin. So each patient has its own syringes in a small bag with the insulin in the fridge. Okay? And every time an injection is done, I know it's a bit of a over precaution, but 2 people need to double check that. People need to be sure it's the right insulin before they do it. Okay? But as you can see, despite all this protocol, we can still have mistakes. I'm very glad that never happened to one of our patients that have been referred. Not that it made a lot of difference, but still. And I'm very happy as well that nothing happened to Tim. He's hospitalized at the moment for some reason, and we are quite careful now. So minimize the risk of mistakes, because you know that if something can go wrong, it will go wrong. Okay? So again, a bit more of question. It's time just to see if the patient is well stable or not. Any vomiting or diarrhea. We talk about drinking and appetite. It's very important to ask that. Is there any difficulty for urination? I don't know if the patient, for example, only urinate on grass. It's very important to know that. And most of all, anything has changed over the last few weeks or the last 24 hours. Because again, that's what will let us know if the patient is stable or not. Okay. And then obviously don't forget the other treatments, any tablets that the dog receives usually. You shouldn't change the routine of the patient. So that's a very important thing as well, and we always ask owners to really follow that. It's very important to have the body weight at time of admission for every glucose curve, and that will be very useful to follow the progression of your patient as well. Okay. So, one thing that's happened with diabetic patients is that they are glucosuric, and as they are glucosuric, they tend to be polyuric, which is obviously quite an issue. And we have frequently some complaints from our nurses because they pee all the time. So there's a sort of comments that we have. We are not very light in medicine because we tend to have to do pee a lot and have diarrhea quite frequently. So there's sort of comment. My dog does nothing but drink, and then he keeps peeing in his kennel. We have too many vet beds that we use. Or he drinks all the time, but he won't pee in his kennel, so we have to go outside, and it's raining, so it's quite annoying. Or this cat is just like wetting himself in his litter tray because he's so urinating. So one people could possibly think that the best way to stop that would be to reduce the amount of water, because if they drink less, then they will urinate less. But it's very important not to make this decision. So why do we ask to keep them adding water all the time? We did mention about osmotic diuresis. It's the fact to have a lot of glucose in the urine that will attract water and induce polyuria. The polydipsia, which is an increase of thirst, the polydipsia is therefore a compensatory mechanism to avoid dehydration. The patient is dehydrated, and that's why he's drinking. Okay. If you cut down the water intake, the patient would dehydrate quite quickly. And even if you don't restrict, if you don't want to restrict water, it's very important to keep an eye on this, because they can drink quite a lot. And sometimes the water bottle can just be empty in 10 minutes. And do not let that happen. Always keep an eye on the water bottle. They need to have water. And unfortunately, the only way to take care of the excess of urine is to while they're not more frequently. Okay? So very important information. Water is life, as is another problem, we did talk about the risk of infection in diabetic patients. That does happen quite frequently. So it's very important to avoid the risk of catching it. So overflow incontinence, again, if they are not urinating frequently enough, this excess will increase the risk of having ascending bacterial infection. Any kind of retention for neurological enormity, for example, or an obstructive lesion. So patients that do have diabetes but do have also a problem with their urinary function need to be assisted and helped. It's very important. They have higher risk of developing UTI and then nephritis. And it's very important to limit the risk of UTI to keep a good hygiene. I think that's something that is in the standard. So, generally, to talk about the glucose curve, is it essential or frustrating waste of time? I think it's a bit of both. Again, I don't think you need to consider that any test is the only way to manage your patient. And we did mention clinical signs is the most important thing. And that's why we need the input of the nurses from that. But the glucose curve will sometimes help you, frequently in fact, help you to understand a situation that doesn't seem to be concerned. So that's one case. It's been quite a tricky case that James saw at Willows. So this dog is Jojo, a 6-year-old Newfoundland, female and diet. That's history of false pregnancy, and she didn't have her last season, and she was quite polydipsic. She was losing weight as well, and she had 4+ of glucose in her urine, no ketones, and relatively high blood glucose. So, looked like she had diabetes. So she was started on twice daily insulin. She received also a high fiber diet. Today there is no problem. But the clinical signs and the glucosuria persisted, so she was referred to Jane. And Jane did some glucose curve. Jane loved doing 24 hours glucose curve. Again, don't think it's the only way to do, and I know difficult it is in private practice to do so. We have the chance to work in a place where we have 24 hours scaling. It's easier. I don't think it's the only way to go, but it certainly helps. I think it gives you 2 curves instead of 1, so you have more information. But in theory, you should have relatively the same level of information. So this dog was 50 kilo, and he was receiving 45 units in the morning, 45 units in the evening. And that's the glucose curve. You see that stay around the 30s. So not very good. So just for nurses, what a glucose curve should tell you normally, that's a normal, perfect glucose curve. That gives you few information. So the duration of action of insulin. So when the insulin is injected there, you see the glucose go down. And this duration is quite variable between patients. It gives you how low the glucose is going down when the insulin is working. That's what we call the nadir. That's the lowest value. Okay. The lowest value that we measure. Obviously, that can be there, but this is the lowest value that we measure. There you go, the glucose nadir. So, and the time for reaching this glucose nadir. There's a bug, it's done twice. So. There we go. So the aims of your diabetic management is to improve as much as you can these 3 elements, but most of all reduce the clinical signs and keep your patient safe. So how do you think Jojo is doing with his glucose curve? Not very good, no? There is absolutely no nadir. I don't think we have any action at all. And it's still quite high, as we say. So the lowest value is probably this one, which should be around 25. So it's really very high. It's no surprise that this dog is having persistent glucose. So the first question is she getting enough insulin? There is no real cutoff to decide when a patient has insulin resistance. Okay? Some people say after like more than 2 units per kilo in total per day is a cutoff, but it's not that close. Okay. It's roughly around that, that's for sure, but each patient is different. This dog was receiving just under 1 unit per kilo BID. So is it possible that we do increase? So that's what Jane did. I think she didn't put the same curve. But basically that's with 55 units, so 10 units more. It's a big dog, so the increase of the dose is obviously quite big as well, especially if the patient is not responding. And again, quite disappointing. So that's the question of what is a normal insulin dose. So I would say that a dog will have insulin resistance when you do increase frequently, or you have increased frequently the insulin level. You can take this value of 1 unit per kg per injection, so 2 units per kg per day, but I don't think it's a clear cutoff. And most of all, the blood glucose is persistently high. So what can cause insulin resistance in general? We can go back to our list. We say it could be infection, inflammation, immune-mediated disease, hypertension, obesity, and diabetogenic hormones. So I don't know if you remember the history of this dog, but there may be something that can help you. This dog had missed the last season, had forced pregnancy as well. Is it possible that this dog has a pyometra? Or UTI? Sorry. Actually, I'm trying to say pyometra. So the owner is bringing some urine sample from Georgia, and that's the result of this urine analysis. We have then an active sediment with inflammatory cells, but no real trace of infection. And there is glucose, as we expect with the patient that has diabetes. So no obvious UTI, but theoretically you need to do a culture to exclude that. My suspicion of pyometra was not bad as well. I think if you have a patient with this sort of history, you need to obviously biomet the patient and see if you have a suspicion of pyometra. Do them in this case another stay important. Obviously, you probably have more signs if you have a pyometra, but some of them are quite moderate. So go back to the list. We rule out an infection cause with this dog, or at least we rule out the most obvious one. Again, we talk about hormones as possible cause of diabetogenic effects. And this dog is not spayed. So obviously, every time there is a cycle, there is an increased level of progesterone. So could be that the dog has all these diseases, pancreatitis, pyometra, UTI. We did look for it, we didn't find it. But maybe this dog just needs to be spayed. And I think that's a very important information to take. The female entire that has diabetes most likely will have uncontrolled diabetes every time she has a cycle. So do think about spaying this patient if they have to put enough obesity to do so. And as the dog glucose curve before and after being spayed. Okay? There's marked difference. Okay, the same dose of insulin. It was a 45 units. That was the outcome, 45 units. So it doesn't look quite impressive because the scale is up to 35, but that's a nice drop. So start at 15, drop at around 7, and then go slowly down. So it's a nice curve, and the clinical signs of the patient will improve as well. But then 6 weeks after the spay, the dog started to drink more again. She was still eating weight, but she was losing some weight. And then she was relatively quiet on walks. And the urine glucose was negative on one occasion, but otherwise has always been 4+. So again, negative urine glucose, flag up hypoglycemia. And that's the 24 hours glucose curve of this dog. She really wanted to put this message. The points on the curve not to miss. This value here, look at that, it's very low. It's around 2-ish. And just after that, a huge increase in the glucose level. That's a true case that she had. So this dog had Somogy. Yeah. Because we removed the cause of insulin resistance of this dog, she didn't need as much insulin. And staying on 45 units was too much for her because she progressively lost this progesterone inflammation. She progressively didn't need as much insulin, and therefore she didn't hypo. And that's again a tricky one because if you had done the curve at this point, as we said earlier, you would have missed it. So how should we do when we have a patient that we suspect could have a Somogy? Again, if you need to think about it, what I would recommend to do is quite a scary thing to do, and if you need to discuss that with them quite a lot to make them understand this, you decrease the dose massively. Decrease the dose by 50%. Just do a step back. Admit to the owner that it's possible we have been too quick. Explain the principle that sometimes you can miss it, but do this step back. Because if you do that, you should see an improvement of the clinical signs, and you should see a glucose curve that will start to look a bit better. Okay? And that's especially true if you know that this patient had before the cause of insulin resistance, and that is insulin resistance that disappeared. Typical example, a patient that had been obese, has been treated with the value for his body weight when he was obese. Then he lost some weight because the owner was quite careful. Therefore, he needs less insulin because he has less insulin resistance, but also his real body weight is probably leaner than that, so the dog is trained to control glucose. Okay, so it can happen with this sort of patient. So don't think that the 24 hours glucose curve will always show that. We said it can be up to 48 hours. If you really want not to miss a Somogy, you need to have continuous glucose monitoring for 1 week, which is obviously impossible. At least not at the moment. In the future, we will have that. So, Somogy effect, that's the other name for hypoglycemia-induced hyperglycemia. So you have an hypo and then, as a reflex, an hyperglycemia. And as we said, the hypoglycemia can be short-lived, but the hyperglycemia can persist. So that's the future. At the moment, we are not there yet. There are some implants that can be used to monitor glucose. It's obviously going to change our life if at some point it becomes cheap and easy to use, but at the moment it's not the case. Another patient of Jane, another one from Willows. It's Wolfie, an 8-year-old male neuter cat that was drinking excessively, was lethargic, was more hungry than usual. So again, looks like he is typical for diabetes. Will be typical for hypothyroidism as well. He's losing weight, and he used to be 6.2, he's now 5.7. And the first examination are urine analysis and blood glucose. And you see that the blood glucose is high, but it's not massively high as well. We have seen with the dog earlier that can go up to 30, sometimes more than that. And if you look at this, you have glucosuria. So you have glucosuria and hyperglycemia. So what do you think? You know that this is probably a trick, but can you say that Wolfie is definitely diabetic? No. No. Cats do have stress hyperglycemia, and if they have been stressing for the last few hours in the car, then in that case they will have they will have the glucosuria as well. Okay? This level of hyperglycemia will be seen in the urine anyway. Okay? So unfortunately, cats are a bit tricky. And that can happen in dogs as well, but far less frequently. We have more difficulty to be certain that a patient, even if he has no glucose signs, has diabetes. So Jen did further investigation to try to differentiate that from stress hyperglycemia. She did fructosamine. It was high, okay, about 80. She did some abdominal ultrasound to be sure there was no chronic pancreatic changes with normal. She did FPLI, and it was still called FPLI, normal. And then she redid the blood glucose after not giving any food or not stressing the cat, and it was still high. So, do you think he is definitely diabetic? Becoming more convincing. It's it's very difficult to be completely sure, even with all this panel, because unfortunately that we discussed about this is not an ideal way to monitor or diagnose diabetes. It's tricky, it can be falsely elevated for a lot of different reasons. And that can still be within the range of being stress hyperglycemia. I would be quite tempted to think this cat has diabetes, definitely. But Jane was not completely convinced. So she was not sure if she would go for treatments just with diets or if she will start the insulin. She decided to start the insulin, if I remember well. Yeah, she did. And she found that 2 weeks after the insulin was started, the weight was stable, the cat was still PUPD, and the appetite was good. So she did some glucose curve, and that's one thing that we need to remember. We say cats can stress quite a lot. The best time to admit them is before the barking dog, so early in the morning before everything is happening. And that's the curve of Wolfie. So he's receiving 2 units of cat insulin twice a day, which is 0.5 unit per kg twice a day. So this is standard starting dose. And you see, he starts at a lowish point initially, and then that climbs up, and then after he has a mild decrease, that's 10. For once, that was not a 24-hour square. So it doesn't seem that Wolfie is very controlled. So she decided to increase the dose of insulin. And you see it's even worse than when he was on 2 units per insulin. That's very convincing that this cat has constant hyperglycemia. So she continued to increase, but the cat was still not controlled according to the glucose curve. And the glucose signs were not markedly better. So what are the main concerns about the in-hospital glucose curve for cats? Stress. And during the day, taking all the bloods, like moving them all the time to take bloods and seeing other patients, sometimes seeing dogs walking around, will stress them all the time. That's not their normal routine as well. It's very difficult to do a glucose curve in cats, especially with stressy one. I will always try, but if it doesn't look right, and especially if it doesn't fit with the clinical signs, then in that case, always thought about the glucose curve in cats. So what can you do to avoid that? You can try to have a stress-free technique, or at least stressless technique. The ear prick technique seems to be more tolerated in cats than taking blood at the jugular vein or cephalic vein. And you don't need a lot for doing that. So we're going to show these. Basically, you take the ear of the cat, you just put some swabs under, otherwise you may prick yourself. Just with a small needle, or you have some device that can do that as well. The one that has been, I think, given by, is it Kenzie who does that?
It's Alpha Track.
It's Alpha Track, yes, indeed. It's quite a nice device. But you can just use a needle if you don't have the device. It's working as well. What you can do as well, I don't know if you see from there, is put a bit of Vaseline on the area that you want to prick. That will isolate the blood and avoid that it will spread around onto the fur. So you have a nice small drop, and you can use your device to directly go on this drop. And it seems to stress less the cat and having better, more reliable results. So we do always do a prick testing in cats at Willows. It didn't work with this cat, unfortunately, but there is another way to manage that, doing some home monitoring. So there is pros and cons in doing home monitoring. Again, we probably will have the same problem than with the urine dipstick. It is not for all owners. Okay. So it is potentially stressful for the owner to do so, more than for the patient. It's dangerous that they may do that too frequently because they want to do too well. So that will stress the patient, maybe break the link that they have with their pets. But that can be useful to be sure that there is no hypoglycemia just before giving the insulin. It's very important to consider that as, again, part of the management, part of the monitoring, but not the only thing. And it's very useful if the owner that are doing that also complete the diabetic diary. Okay? So they will be able to show you the glucose curve and what happened that day, that the risk cat was not eating very well, that the risk cat had some stressful events that will really help you to understand this glucose curve. But again, be careful. Do not give the opportunity of very intense honor to honor you every day by giving you some glucose curve that are not completely controlled. This type of honor, probably the least amount of monitoring is the best. I don't say that we need to completely disregard what they say, but a lot of people that do manage diabetes tend to be extremely stressed by the situation and will create a sort of stressful environment around this situation, asking more questions than needed, thinking that things are not getting well, and the only thing that will happen is that it will influence your judgment on how to manage the patient, and you may take wrong decision. So it's important to calm down this dishonor, and giving them this home monitoring may not help. So back to Wolfie, he had some home monitoring because the owner was quite a quiet lady, and that still showed a poor response to insulin. So she did increase, and as you can see, she did increase the dose of insulin to a massive amount. So the cat was receiving 20 units twice a day. There is no doubt that this cat has insulin resistance. Okay, the dose is massive. It's 5 units per kilo twice a day. But as she couldn't find a cause for insulin resistance, she was basically she had no choice than to increase the dose. So Wolfie is very insulin resistant. We have Orlis as usual. Don't forget neoplasia. So what sort of test you can do if you have all of these? We did talk about this briefly. Urine culture to detect UTI, very frequent. Routine biochemistry and hematology to see if there is any other disease. Looking at the T4, it's normal. And looking finally at the IGF, insulin growth factor, and that's high. So this cat had acromegaly. So this is one of the newly recognized and more frequent diseases that is associated with insulin resistance in cats. There is, I think, a diabetic research center that has been started in the RDC where they will study, especially acromegaly, but a lot of other diseases as well. It's amazing what they do there. And they do recognize that acromegaly in diabetic cats is especially frequent. Be careful. Patients with diabetes can have high value of IGF without having acromegaly. That's especially true if they are not controlled for some time. That will increase the growth hormone of the IGF, and therefore you may falsely diagnose acromegaly just based on that. Okay. So don't think that the patient has acromegaly just based on this value. Unfortunately, you need to have some pituitary imaging to confirm it. Not all people can do it. But if they want to treat it, the treatment is radiation therapy, and radiation therapy, surgery as well. Again, the RBC has started to do that. It's not yet available at Willows. It's quite a technical and challenging surgery to do. But radiation therapy as surgery, obviously, will not do that if you have not implanted pituitary mass. So it's not for all owners, but it's very an interesting disease. And they don't always have the typical aspect of acromegaly cat with broad facial features or good teeth. They don't necessarily tend to present like that. In fact, I've never seen a typical acromegaly cat, probably because we diagnosed them a bit too early now. Or we were not diagnosing them early enough before, let's say. So for the diabetic clinic, what is important is to have finally not a lot of equipment, but quite a good team, which is train and follow a protocol, a sort of standard routine, and how you manage the patient. And again, I really want to stress out the very important role of nurses for that. It's very important to have good communication skills. It is stressful, this situation, for both the owner and the patient, so you need to be yourself quite patient and empathic. You need to be organized to limit the stress. You need to reduce the stress of the patient, especially cats, by manipulating them nicely. And again, give all the information that you can to the vets. Ideal for that nurse. So just quickly, just to show you that the world of diabetes is not always ideal. I won't talk too much about Oli because I don't know Oli, but I know Alfie is one of my patients. It's here, Alfie. Quite a lovely dog. But this dog had a lot of diseases. So he was diabetic, but he also has EPI. And in fact, his disease is related to a very severe chronic pancreatitis. So he doesn't have insulin production by his pancreas, but he doesn't have as well pancreatic enzyme. So he's on supplement for that. And he had associated SIBO/antibiotic responsive diarrhea, which is quite frequent in patients with EPI. He also has microbiome disease, but it's a problem. And he has a very original type of monitoring, management, has been seen by Jane since she was at Willows. It's been years that she's following Alfie. And Alfie has always been responding quite weirdly to insulin. So he's on Levemir, okay, and he's also on Hyperion in the evening. So he has Levemir in the morning, Hyperion in the evening. When he had Levemir twice a day, it appeared that he was too frequently having hypoglycemia. So after long try and error, Jen managed to find that that's the best way of stabilizing him. So it's quite unusual. I do not recommend to do two types of insulin because it's quite difficult to control, but that's how it is. And Levemir, we say, is supposed to be less fluctuating. It's supposed to be just a relatively flat curve. That's what we have with Alfie. Okay? And he did have relatively good clinical control as well at this level. But he starts extremely high, improves quite low, and then high again. And every day is different. That's day 1. That's day 2. Woof. Okay? So again, with that, you can definitely suspect a SOMO-G, because it goes low at one point and then it goes high after. It's not always easy to diagnose. This one we have tried to decrease the dose, that has not changed at all. I thought that it was more diabetic after that. So that's an example. Unfortunately, it's not always as it should in the book. I get a bit more of curve from him. That's all the try that she did. So in summary, diabetic patient can be quite challenging and frustrating. And the best way to manage this and not having a nervous breakdown because you cannot stabilize your patient is to keep it simple. Really rely on the clinical side, that's very important. But most of all, you need to be realistic. You cannot fix all the diabetic patient, that's for sure. And the goal is not to have a perfect control. The goal is to have a good quality of life and having a patient that live as long as possible with this good quality of life. You will not beat the diabetes, it will always be present, and at some point the patient will be stabilized. The only thing we can do is to help them as the best we can. Okay? So I think that's all. That's close our presentation. I don't know if you have some comments or anything you want to ask about diabetes management. How are you doing here? Do you have like the nurses hospitalizing the patient for diabetes?
The nurses do a lot of the hospitalisation, but we're trying to get more nurse involvement in clinics, and that's what we're hoping to set up over the next few weeks. That we've got some places doing a lot and some that are just starting.
Okay.
So, my question would be, you look like you're doing your curves, blood glucose every 2 hours.
Yes.
We've had a lot of people suggesting 1 hour lead. What do you think?
I think we have enough information with 2 hours, personally. You won't be able to know exactly the nadir, for example. You won't be able to know that. Because even if you take every hour, nobody can tell you if in the 30 minutes there is not a lower value. So I think we have enough information, a sort of a general shape of your curve every 2 hours. But those limits the amount of tests you do, so less work for the staff. That does limit the stress on the patient as well. I think it's a good balance every 2 hours. I do tend to do that. When I start insulin for the first time to be sure there is no hypoglycemia. I do every 4 hours because I don't care about the shape of the curve just after starting it. Just want to be sure there is no hypoglycemia. But otherwise, I tend to do every 2 hours because I think it's marginal.
So, do you think that if it goes very low, it's better to like every hour at that point, or just stay with it 2 hours?
It can be an option, but if you already know that it's going to go low, the exact value will not change how you will manage your patient. If a patient goes low, and Alfie, I don't know if you saw in the curve at some moments where it went very low. There we go. So this one, for example, was quite low. It's quite scary, and we have been scared when Alfie started to do this sort of rather, but he's doing well with that. He never had any clinical sign associated with it. So we didn't change the protocol based on that. Because if you decrease the level of insulin, it's not controlled anymore. So I would say that the exact value will not tell you how the patient will react to that. Every patient is different. Some patients are quite used to have relatively low level of glucose that will not create any problem for them. And again, that's very important to consider the clinical signs. Some other patients with even higher value will have seizures. So then in that case, obviously, you will have to act and change. So the exact value anyway will not be the lowest value. We don't know if it is the lowest value. It's possible that 10 minutes before it's even lower than that. So I don't think it is very important. It doesn't really matter to know the exact number of the matter. It doesn't change how you manage your patient. And unfortunately, the nadir is not always at the same time during the day. So it's quite classical to have a patient after 6 hours the first glucose curve, so you tend to concentrate on the 6 hours after, and then at the end it does that 12 hours or after. And I did mention that every patient is different in facing the insulin. There are some patients, it's a bit the case of Alfie, that will have a rapid onset of action and then it will disappear quite quickly for the insulin. So this patient sometimes, it's quite tricky to repeat that, will benefit either from having a longer type of insulin, like Glargine or Lantus, or maybe doing even 3 injections of insulin. If it's absolutely not possible to use Lantus or Glargine for some reason, you can go for 3 injections, but you need to be sure that your patient has a quick action, and then after no more effect, you need to see that it's less than 8 hours before doing 3 times. It's very uncommon, and I think it's easier to use a longer action type of insulin rather than that. It's 3 injections per day, and sometimes there are people that can do that.
The longer acting peakless ones, where is a good source of information? Because obviously they haven't really hit textbooks and stuff, so it's quite hard to find what you should do with them.
Yeah, mainly in the vet journals, so I think Journal of Veterinary Internal Medicine is probably one good one. They publish a lot on diabetes. One good news is that it's going to be free quite soon. This journal, that's the official journal of the European and American College of Internal Medicine. It's going to be free for everybody. So you don't have to pay the access. I think it's next month. So it's going to be
really? Oh, wow.
And so people that want to publish will have to pay a lot. But at the end, when it's published, it's open to everybody. Unfortunately, even to owners and people that may interpret them.
Oh no!
Exactly. But that's the future of veterinary publication. I think all journals will do that open publication now, because it's. I think it's the nicest way to do for most of the vets. Unfortunately, that may reduce the amount of publication that will be done because the cost of it will increase massively. So, but yeah, they will be free quite soon. They just talking about diabetes. They just put in publication, so the early view publication, something on cats and diabetes, giving some intravenous continuous insulin over a few days will improve the management. I didn't read it yet, but it seems that the more you are aggressive with cats, the better it is.
How common do you find diabetic remission in cats is, and how many of them then go back and get it later, would you say?
There is no exact numbers. I will tell you my rough idea of how it is. I would say that probably 20% of the cats can have a remission. That would be even more likely if you do that early, if you treat early and quite aggressively. You improve the remission if you do use glargine compared to penicillin, but unfortunately we don't have theoretically the right to start with glargine. And if you decrease the cause of insulin resistance, you will increase this percentage of success and so forth. Very frequently, again, I don't have the exact value in mind, but very frequently cats that have been diabetic once will be diabetic in the future again. Because they tend to have relapsing insulin resistance for some reason. And if they have been diabetic, it means that they anyway have relatively poor insulin production compared to normal. So they do tend to develop diabetes eventually.
Do you just do like weekly dipsticks to try and pick them up early again?
I just based on the clinical science, yes. But it is an idea to do during dipstick. But again, it's not because there is glucosuria that you will have diabetes. It's not because you have hyperglycemia that you will have diabetes as well. So it's always the tricky thing of cats of knowing if they are diabetic or if it's just stress. And that can happen in that form.
I've just got a question about testing for Cushing's and diabetes. And just a bit worried about some of the stress-related factors of having diabetes and that influencing Cushing's tests. Which do you prefer, or do you?
It's a good question. It's quite tricky in general to diagnose Cushing. There is no test that will be perfect, unfortunately. We don't have Synactin anymore, so I tend to favor low-dose Dex. What I do generally with patients that are diabetic and I want to exclude Cushing, I do tend to ask for urine cortisol and creatinine ratio. So I think if it is low, that will exclude your Cushing. That's quite a good test to exclude this. After that, if it is positive, and that can happen, and again, sometimes it happens because of the metabolic stress associated with diabetes and all the insulin injections as well. So in that case, that will be more tricky. You cannot trust fully your low-dose Dex with Cushing, so you tend to add more information by doing abdominal ultrasound, for example. You looking for this raised ALP, which is not specific obviously, but you need to have a lot of information before being sure.
Just an ACTH.
I don't tend to use it anymore, but that's mainly because Synactin is not as available as it was. I tend to keep the ACTH skin test only for hypoadenocorticism, so suspicion of medicines.
We've got pretty good access to it at the moment, Synactin.
We do?
Well, the the imported one.
Okay.
So
we do still have some difficulty to have it, but do you know that you can freeze it? You can, you can use somebody putting freeze it.
I think it's going to be Decra bringing it back to the market early next year as a UK license as well, so it's coming back.
So the problem with ACTH skin test is not as specific as the low-dose Dex. So if you have to pick one, you have to take the low-dose Dex. Again, we tend to restrict our ACTH skin test now, but it's not a big issue to do.
So this test is better for Cushing's and
the ones that are insulin resistant, for sure, you need to think about them, especially if they are the breeds that can be predisposed to this. But it is tricky. It is not an easy answer to the question. It's easy to rule it out. It's not easy to rule it out.
So if you were to rule it out, probably you would.
Yes, that's at least a good thing. We can rule it out. But it's very difficult to diagnose it. Even in normal patients that do not have diabetes. Okay? Any more questions? Do the nurses have questions or no? No? Okay. I don't know if you have more questions about anything else, because I'm available if you want to talk about any other case or any problem that you have. No? Fine?
Can I say big thank you? That was a brilliant talk, really.
Thank you for your patience with my